I think we have a lot of new audience as well coming in. This is our Wednesday academic session, which happens every week, mainly critical care focused, and happens at 8:30 to 9:30 every day morning. It's an internal session, primarily for Cloudphysician and its partner hospitals, but we do have some of the folks joining us today morning as well. So here we go. So today, the topic we are going to cover is tropical infections in ICU. It's a fairly vast topic, so to speak. Only, you know, 100 or so diseases, but I'll try to cover the most important ones. And the slide layout is basically going to be first talking about the general principles of care, what are the common infections, and some pointers on how to deal with some of these tropical infection syndromes in an Indian ICU. This is purely going to be from an Indian context, and perhaps we'll need more sessions to cover individual diseases. Maybe if I have time, I'll maybe touch upon malaria a little. Otherwise, we wouldn't really have that much time in less than 1 hour to cover a lot of these other diseases which commonly present in ICU as well. So what's the definition of a tropical disease? Uh, Quite often we think it's just malaria or just dengue or uh, these arboviral diseases or vector-borne diseases to be tropical diseases. Actually, yeah, it's in a way true that mosquitoes are more common in tropical areas, but there are various other diseases which could be something like typhoid or tuberculosis or colors, or there are plenty of other diseases which are almost exclusively found endemically. Endemic means something which is normally present in the uh, location, geolocation, and which is something normally present in that particular geolocation endemically, and does occur sporadically everywhere else as well. And it's not unusual to see some of these tropical diseases in temperate climates as well. But this is the Webster Dictionary definition. Now, available data, there isn't a lot actually published on the composite data. Time to time, WHO does give out statistics on specific diseases, and the most amount of data that we have for is diseases like malaria, actually. Dengue is actually slotted as one of the neglected tropical infections. And there's plenty of reason for us to believe that as well. Now, from this is one study published in IJCCM back in 2017. There are numerous problems with this study in terms of overall representation. Most of the hospitals which were recruited were largely, catered around, uh, peppered around North Indian states, and even the South Indian states which had representation had very few patients. Particularly Karnataka and Kerala had, I think, zero representation in this particular study. Nonetheless, I think some diseases we can agree that do represent a bulk of ICU admissions, and the most common admission in this study was found to be because of dengue, followed by scrub typhus. Perhaps this is a little different in Karnataka, Kerala, and Tamil Nadu, where malaria may most possibly be a lot more common than scrub typhus as an admission. And also, it's intuitive to also say that a lot of these dengue patients are not really dengue hemorrhagic fever, but they are just there because of low platelets. And this is something that we commonly see. Somebody has a platelet count of 20,000, 30,000. They just land up in the ICU for just monitoring and platelet transfusion. So this could be one of the reasons this data has come up like this. And approximately 20 to 30%. This is from this 20 to 30% is from various sources of all ICU admissions in the country are tropical infections. So it's very important for us to kind of really know and also have a sense of how to deal with infections. And No guesses, I mean, no marks for guessing that thrombocytopenia and rash is the most common presentation of any kind of tropical infection. And almost 35% of them receive mechanical ventilation. Now, this is a pretty big number. And now this data might have been skewed because of the poor representation of more resource-rich states in the country. So a realistic picture may be something like 20%. But nonetheless, it's an alarming number that almost 35% of Indian ICUs who receive tropical infections get intubated. Now, this is a good to know list. I'm not going to go into the details of it. Some of them you may not even have seen a single case in your life, but some of these do exist in Southeast Asian countries, particularly in India as well. Some diseases like Buruli ulcer is not really that commonly found in the Indian subcontinent. It's more like an African disease. But of note, from an ICU perspective, we do get leishmaniasis or Kala Azar in almost exclusively in the state of Bihar. Dengue is also stated as a neglected tropical disease, and there are a lot of ways they kind of define neglected tropical disease, but the definition or the heading speaks for itself, that something which is neglected and doesn't receive enough importance in the whole grand scheme of public health planning is basically a neglected tropical disease. So leprosy is not really a neglected disease in India. There's a lot of the leprosy mission does a lot of work, and it's almost managed to almost managed to eradicate the disease. But however, we can agree that some of these diseases in the list do land up patients in the ICU. Mycetoma is another thing. Uh, Advanced cases do sometimes come to ICU. Now, some factors that we need to consider while you admit a patient. I'll do the slightly unconventional way of, you know, going or rather, dealing with a tropical infection in ICU. The typical way would be going through your ABCs and labs and investigations and treatment, etc., etc. I'm doing this a little different because there is actually very little you can do in terms of specific treatment for a lot of these diseases, and I'll cover some of this later. Some factors that we need to consider, and we live in a tropical country, so pretty much most of the infections which do come to our ICUs are tropical infections. Now, seasons and ongoing waves of epidemics are very important to consider, because during the COVID season, almost all ARDS cases were considered as COVID, and we do miss some cases here and there, but you're going to be right 9 out of 10 times. And there was this, I think about close to 15, 16 years ago, this huge wave of chikungunya cases which came in, and some of them did land up in the ICU. And at that time, if you placed your bet on chikungunya for a case with uh, fever with thrombocytopenia, you are more likely to be right. Now, dengue and malaria epidemics are common between the month of June and August, and this is to be kept in mind. It's mainly because of waterlogging, etc., which happens, which leads to breeding of mosquitoes. And the region that you live in also is very important. Now, we deal with ICUs in 16 states as an organization, so it's maybe perhaps important for us to kind of be familiar with some of these diseases which come up in some states that we deal with. Now, some northernmost states like Jammu and Kashmir, Himachal Pradesh don't really report malaria. It's too cold. Basically, places which snow do not harbor mosquitoes, not to the extent that it happens in more tropical climates, so to speak. And mycetoma is another disease which is the reports of which is very high in West Bengal. There are some South Indian states as well which do repeat it. And leishmaniasis or kalas are, this can land patients in the ICU, and we actually do see some of these kalas or cases in some of our ICUs in Bihar. And melioidosis is another case, another disease which is almost exclusively found in South and Central India. It's not that common, or at least has not really been reported in North India. Some of it could be because of underreporting, but even in places like metros like Delhi and Kolkata, it's not very commonly reported. Now, it's a very interesting disease. If I have time, I'll talk about it later. But it's something that we need to keep in mind, uh, and it's not very uncommon to actually see patients with melioidosis. And we used to get quite a lot of these in Mumbai, for example. Social Socioeconomic status. This is again a no-brainer. Uh, many infections are common amongst poor, particularly the neglected tropical infections. And travel to endemic countries, I must that endemic locations, and contact with wilderness. Now, it's sometimes common to find diseases like scrub typhus or other rickettsial illness amongst people who have recently traveled to one of the areas which are endemic. And sometimes you also do see places, even cases like malaria and dengue are uncommon in some states of the country, and you might actually find some travel history amongst people who have traveled to these states. And onset and duration of symptoms is not always useful, but sometimes it does help us rule out certain things. One example is scrub typhus. Somebody's traveled to the wilderness 3 days ago and now suddenly has come with an acute febrile illness and acute kidney injury and encephalitis. Scrub typhus, for example, takes about 7 to 10 days after a bite to actually develop. So that's kind of good to have that insight. And also typhoid takes about 5 days to develop after exposure. So some of these little things kind of matter in the larger scheme of things, because you can actually narrow down your whole spectrum of search. Medication history. Almost everybody who visits your ICU has received some kind of medication or the other. And particularly malaria is one disease which is often uh, not treated right. For example, presumptive treatment with chloroquine has been taken out of the national malaria guidelines, I think in 2017 or 18, close to 5 6 years ago, and people do continue to use chloroquine as the first line for treatment in presumptive treatment. And quite often people land up in a soup and partially treated, and that kind of confounds the whole spectrum of disease as well as progression. So it's important to know that some people may have received steroids, which may actually mask a lot of your findings. And antibiotic treatment, of course, again leads to partial resolution of disease, which may actually confound your whole spectrum of presentation, and sometimes even pop up negative cultures, which might actually that's because of the bacterium has abated, but the source remains. So this is important to take medication history, severity, and family history.
Sir, you are in mute.
It's also important to know some diseases like chikungunya, cysticercosis, kalas, or filariasis. There's a entire gamut of these diseases which are almost never rapidly fatal. Helminthic diseases are almost, not almost. I mean, for example, ascariasis or a hookworm infestation is never ever fatal. So it's important to remember this, because sometimes you may have a patient who may have a complex presentation, sometimes with a presentation of uh, abdominal sepsis, and we find one of these diseases and might actually stop searching for something else. So it's also important to know some of these diseases which are never fatal. Patients may have filarious, pathogens in their body for decades before they develop any kinds of disease. Now, the syndromic approach for tropical infections in ICU. I honestly don't really like this approach because I think sometimes we get very myopic with the way we look at diseases. But nevertheless, it's still the simplest way to look at tropical infections, because otherwise the search net is so wide it almost becomes impossible, and you will never really know where to start. So again, even the syndromes are pretty lengthy. In the next slide, I've simplified it a little more. They the list which this both Western studies as well as Indian studies have come up with this approach where you have a fever with rash or thrombocytopenia, fever with ARDS, that is lung involvement, fever with encephalopathy. This comes in the encephalitis range, fever with multi-organ dysfunction where multiple organs in the body get involved, fever with jaundice, a renal-pulmonary syndrome where you have a pneumonitis with acute kidney injury, or an undifferentiated fever where uh, it doesn't really fit into any of the syndromes, but can actually be different kinds of involvement. Now, fever with rash, like I mentioned earlier, is the most common presentation. And in the adult population, dengue still remains the most common presentation, common disease to land up in the ICU. Then there are various others. And if you really want to talk about just fever with rash and thrombocytopenia, there are 100 viral diseases which can actually cause this. And this list is actually not that exhaustive. But nevertheless, these are the most common ones. Dengue, rickettsia, malaria, meningococcus are the most common ones in adults, and measles and rubella, it's more really in the pediatric population. But again, this is where you ask the vaccination history. I think somewhere in the early 80s, MMR vaccination was started, and it's almost unheard of in adults to have measles or rubella these days. However, there would be one of those guys who have not gotten vaccinated. So it may be important for us to just ask this history once. And fever with ARDS, in the last couple of years, 3 years, it has been COVID worldwide. But again, it won't really constitute as a tropical infection because that was a pandemic. And there are various diseases which can cause fever with ARDS. Again, this is uh, more like trying to fit in some diseases which fits into this particular set of symptoms. But malaria is still continues to be the most common cause of ARDS in the tropical infection list in ICUs. Then you have H1N1, uh, leptospiral, and hantavirus is another very important emerging infection. It's not that common, and but has been reported uh, primarily in South Indian states. Vellore had a few cases, and there are some cases in Odisha and a few other states in the east as well did report hantavirus. So pulmonary syndrome with just acute kidney injury, it's one of those diseases you can just keep in mind. I had seen a few cases back in 2009 or 2010. This was in Bangalore, and those times PCR wasn't really available, and it was a little difficult to even get them tested. So that's something which you can remember. Legionella is not that uncommon in India. It's just that we never really test for it. Fever with encephalopathy. Now, the most important disease to remember here are uh, the treatable ones. The Yes, somebody has a question. Uh, Herpes simplex virus, malaria, Neisseria, strep, and typhoid actually do have specific treatments. So these are the more important ones to remember. Then, including Japanese encephalitis, there are a ton of other viral diseases. Now, even amongst the viral diseases, I don't have it on the slide here, there is a family of viruses called the flaviviruses, and within that family you have mosquito-borne illness and tick-borne illness, and a lot of them. But amongst the mosquito-borne illnesses, the flaviviruses, which are commonly found in India, are dengue and Japanese encephalitis. And there is another virus called West Nile virus, which is not very uncommon. So your usual panels don't really cover West Nile virus, but these days there are multiplex PCRs which they do have kits for West Nile, and if you specifically request it, they will actually do it. So, and when you do send the encephalitis panel, just remember West Nile is not completely unheard of in the Indian subcontinent. And the tick-borne illness, there are various ones in the among, but in the flaviviral group, there is just a KFD or Casanur forest disease, which is exclusive to one area of Karnataka, and it's not really been reported even in the Casanur forest after the initial massive outbreak. And other diseases. Now, I'll skip the multi-organ dysfunction. Pretty much all tropical infections can cause multi-organ dysfunction once they're severe enough. And fever with jaundice, this actually has a little bit of narrower spectrum. Again, once the patient is in shock and disseminated infection, anything can cause jaundice. But presentations with jaundice, hepatitis A, E, leptospira, and rickets have narrowed this down a little bit. Malaria also can cause involvement, but it's not that common. AE, lepto, and rickettsia would be your first diseases to search for. Rhinopulmonary syndrome, again, dengue, typhoid, lepto, scrub typhus, hantavirus. I mean, if you actually go through the list, everything can cause everything, and this is a little bit of a you know oversimplified oversimplified classification. Now, broadly, when you actually look at this, the approach that I follow is just, of course, we do have to have the syndromic approach in the back of our mind. Put the illness in one of these five categories. Is it a pneumonia? Is it a meningoencephalitis? Is it an abdominal illness? Is it a urinary tract infection? Or is it renal or hepatopulmonary or renopulmonary? Broadly, all tropical infections which are differentiated fall into one of these five criteria. And we need to kind of basically, like in when you read an ABG, you have the primary disorder and the and the compensation. So similarly, it's kind of important to go back, dig into the history, and find out how the disease started. Did the disease start as a pneumonia? Did it start as a meningoencephalitis? Did it start as abdominal? Did it start with abdominal complaints? Did it start with urinary complaints? Or was it a complicated presentation to start with? So this kind of gives us a clue on the etiology of the diseases. Then there's no real easy way of remembering all these illnesses, but do remember the big 3 or 4: malaria, dengue, scrub typhus, leptospirosis, and typhoid. Sorry. Now, again, all these things which can cause differentiated infections, the common big 5, they can also cause undifferentiated fever. Basically, it means you don't find any localizing signs whatsoever. You just see fever, and the presentation is just fever. This can happen as well. So now again, syndromic approach, a lot of diseases, a lot of tests. Where do I really start? Just putting in some stuff here from things that I have read or experienced over my career. This is turning out to be more of an internal medicine presentation than a critical care presentation, but that's how tropical infections are. Deep knowledge of certain diseases in depth is kind of needed when you're dealing with these diseases, and it's primarily about diagnosis rather than management. Management for tropical infections pretty much has a simple template, to be honest. Now, malaria and dengue, doesn't matter what the history is. Does the patient have, it doesn't matter if the patient does not have chills, doesn't matter if he does not have a quotidian kind of fever distribution, doesn't matter if he does not have thrombocytopenia, doesn't matter if he was diagnosed of dengue and discharged recently. Test for malaria and dengue. It's rapid, it's inexpensive, it's available everywhere in the country. Test for it in every case of fever which comes to your ICU. And in case of patients having abdominal complaints or jaundice, test for typhoid, hepatitis, and leptospira to start with. Then you can kind of widen the net, and as and when more clues pop up, you can search for other diseases. But this is where you start. In case of encephalitis syndrome in some parts of the country, you don't delay the LP. Of course, we can start with malaria treatment, because cerebral malaria does present with encephalitis, and it's one of the most common causes. And if the dengue test comes out positive, I would still continue treating for malaria unless I have confirmed that it is not malaria. That is, we have done all the tests, that we have done the rapid diagnostic test, and we have also done a QBC, and it is negative. Sometimes we have gone to the extent of doing PCR in some cases, but that is extremely rare, because malaria and dengue infections are also common to occur together during season. Now, herpes simplex virus, it's something which you will get a clue when you do a CT scan of the brain. You will have bitemporal hyperintensities, which actual hyperdensities, which can crop up on a CT, or hyperintensities on an MRI. And I would not delay a lumbar puncture on any of these patients. Just make sure the platelet counts are adequate. Typically, we need at least 1 lakh. We have done it as low as 80,000 or sometimes 60,000. But if you don't want to play maverick, 1 lakh is the safety net for platelet counts. Do transfuse some platelets before going in and doing the lumbar puncture. And test for Japanese encephalitis in endemic regions. Now, Japanese encephalitis, there was a time when, people used to die in hordes, and there was this really sad a phase in Indian history where thousands of children died, approximately 100 in 2005, and even as recently in the last decade, there were certain states in India which had approximately 100 or 200 kids die, and more than 5,000 cases. But nonetheless, the total number of Japanese encephalitis cases which constitute encephalitis in the ICU is less than 14%. So mass vaccination is something which people have questioned, and in fact there have been very florid debates on whether we should even continue this as a part of a vaccination program. But the number of cases nevertheless have come down very significantly, but it continues to happen sporadically. So it's important to test for GE, particularly in the states of Uttar Pradesh and Bihar. And now with the migrant population, it is also spread over and spilled over to other parts. So this is again very important to ask where a particular person, a patient, is originally from. Now, also send blood cultures in all cases of severe acute febrile illness in ICU. Severe acute febrile illness means the patient is in shock or has organ dysfunction. And if you have a BACTEC and a YTEC or a BD or whatever automated culture method you have, it's widely available in most metro cities and even tier 2 cities these days, and even tier 3 cities in certain pockets. Just prefer our automated cultures whenever available. Again, standard 2 sets, that means 4 bottles, 2 bottles of aerobic, 2 bottles of anaerobic, and this is very important. And also, when a patient lands up in your ICU with meningitis, do not forget TB meningitis as a differential. It's a great mimic, and in our country, any kind of presentation can happen because of TB meningitis or disseminated TB. So any patient with chronic respiratory symptoms, meningitis, do rule out tuberculosis as well. And Vidal test, it's obsolete. There are multiple reasons why Vidal test is obsolete. If time permits, we can talk about it, in the end of the talk, if anyone wants to really know more about why Vidal is obsolete. And Typhidot, uh, yeah, they say the specificity is around 80% and sensitivity is around 93%. However, it's still inferior to blood cultures because these studies which were done actually took blood cultures as the gold standard. There were some plenty of false positives, there was plenty of false negatives, but again, 83% specificity is decent enough because one thing is it does return uh, faster than your cultures. So maybe as an initial test, you should it's an okay test to do. But after that, once the cultures have come back, it's probably uh, not something which we should really consider. Now, disease specific clues, there aren't a lot. There are hundreds of diseases, but there are some diseases which might actually give you a clue. Scrub typhus and Mediterranean fever. So it's also important to kind of be familiar with the kind of rickettsial infections which are seen in our country. Amongst the common ones in our country, scrub typhus, and we call it Mediterranean fever, botanist fever, etc., etc. This is basically rickettsia gonorrhea infection. The difference in the escar between scrub typhus and Mediterranean fever is that Mediterranean fever not only has an eschar, it also has a lot of purpuric spots. Now this comes under the spotted fever group, very similar to your Rocky Mountain spotted fever in the west. But in India, these two are the most common ones. Mediterranean fever is more common, or we call it Bhutanese fever in India. It's more common in some of the northern states. Chhattisgarh, I think, is one of the hubs for this. Now, rose spots of typhoid, it's again it's not just one thing, it's not like you'll just go in and pick up an eschar. It's a combination of all the symptoms that you need to consider if it really fits into a particular disease. The patient come with abdominal complaints, then has a disseminated infection where his multiple organs got involved. In that patient, you find this spot on the back. You could suspect typhoid. Now, the one important feature of rose spots of typhoid is that these blanch. You place your finger on it, the spots actually disappear. That opposed to a meningococcygeal rash or a rickettsial rash is very different. Meningococcygeal rash is a little different. It starts out as purpuric rashes and then transforms into something called purpura fulminans, where it just becomes evanescent, and there are this hemorrhages. And in addition to this, there's multiple other things. In fact, in dengue, one of the tests which they do is capillary fragility test, where you tie a tourniquet and inflate it and look for appearance of uh, hemorrhagic spots. But we don't do it that often any longer because it's not very difficult to get platelet counts done. But if you are in a center where it's pretty much impossible to get a platelet count at that point in time, a capillary fragility test for dengue could actually give us some insight into whether there's a bleeding tendency or not. And now, other disease specific clues for malaria. This malaria, like I said, it's usually treated with the moment anyone gets fever, you do start them on some kind of antipyretic. So these days, it's not really common to find the typical uh, fever patterns of malaria, but it's good to know because sometimes when the parasite load is high, despite antipyretics, you will still find this kind of pattern, quotidian fab pattern, which can be seen in both falciparum and Nolaci. Falciparum is the one which is found in India. This is basically a spike and a trough every 24 hours. A tertian pattern, which is seen vivax and ovale, where you get a break of 1 day in between fever, and or a cotton pattern in P. malariae, where you have fever, 2 days no fever, again fever. So P. malaria infections as an isolated infection almost never occur. it's usually admixed with Vivax or falciparum, in which case you can get different fever patterns. And even though these are specific fever patterns, it's not very common to really see them in the kind of population, which particularly the one which comes into the ICU. Typhoid, uh, two things: relative bradycardia and crow's spots. I already spoke about. We all have already spoken about this. I mean, already know this relative bradycardia right from our microbiology days. That's the patient is febrile. However, there isn't that much of tachycardia. So for every degree rise in temperature, you should actually find about a rise in 10 beats per minute of heart rate. If that does not happen, that basically means the patient has relative bradycardia. It's one of the signs of typhoid. Nevertheless, can sometimes occur in multiple other causes as well. Now, another very interesting thing, it's not really a classical sign, so to speak, but this is an important clue. If you see an eosinophil count of 0 in a patient who is suspected to have a tropical infection, typhoid should be on the top of your list. This almost exclusively happens only in typhoid, and this in the context of uh, tropical infection. There are multiple other causes of getting a absolute eosinopenia, but it's a very interesting thing to note. If you see eosinophil count of 0, think typhoid. Patient has come with encephalitis. You've done an MRI. Your whole basal ganglia lights up, and bilateral thalamus lights up, and hyperintense signal changes in the midbrain. This is where your flaviviral illnesses, your Japanese encephalitis, West Nile, and all that come into picture. Now, particularly basal ganglia and thalamic involvement is very common in Japanese encephalitis, and if you're living in the right region, these two MRIs are actually from patients of Japanese encephalitis. You can see the basal ganglia and bilateral thalamic involvement here, and here you can see the midbrain being all bright. Now, there is West Nile encephalitis, which can also cause similar kind of a picture. And if you do have patients who have, been internationally on international travel, then there's another entity called Murray Valley encephalitis, which can also present with very similar features. Now, investigating a tropical fever in the ICU, we can go, disease by disease, but I'll just give a broad overview on investigation. The routine labs, your CBC, RFT, LFT, ABG, just X-ray, you do it for all patients. This urine microscopy, ECG, and if you do find any changes, please do an echo. Some of these viral illnesses can cause myocarditis as well, and even enteric fever can cause myocarditis. So it's important to remember that. And any patient has shock, doesn't matter if the counts are normal, you should do blood cultures, because there are plenty of bacterial illnesses which actually over a period of time overwhelms the bone marrow, and once the bone marrow stops functioning or reduces its overall function, the counts may actually be low, and you might actually be falsely suspecting uh, viral illness as opposed to bacterial. So blood cultures should be a part of your routine labs in patients in ICU who are in shock. Dengue positive, patient is perfectly stable, just come into the ICU for platelet counts. Please don't send blood cultures on such patients. But anybody else who's reasonably sick, please do send it. Now, specific tests. Again, this is not really from any guidelines per se, or rather a collection from multiple guidelines and multiple sources. The step one, again, always going to be malarial parasite. Now, rapid diagnostic tests, if I have time, I'll talk about them at the end of the session. But overall, it's important to kind of go to the lab and ask them what kind of rapid diagnostic test they have, because there are 3 or 4 kinds of rapid diagnostic tests, out of which three is available commonly in India. The histidine-rich protein, the PF-HRP2 test, which is specific for falciparum, is one of the tests which is used. Another one is a rapid kit which detects uh, LDH, and there's also one more which uh, detects plasma aldolase. Now, aldolase is an enzyme which with this PMA test, it's common to all three. That's commonly found: malaria, vivax, as well as falciparum. Now, one thing to remember is while histidine-rich protein is specific to falciparum, the other two tests kind of help us pick up mixed infections. But it's also important to remember, quite often you see lab tests which say falciparum positive, OVL positive, and Vivax also positive. So it doesn't really happen that way. It's these tests do not differentiate between various species. These tests will tell you if there is a mixed infection or not, if there are three kinds of infection, two kinds of infection, whatever. But they don't differentiate. The only way to differentiate is to do a smear or a PCR. Now, doing a smear is tedious, so you will need to sit with your lab technician, sit with your microbiologist, or at least give them a call and tell them specifically that, hey, we are suspecting a this is a complicated case, and we need to know what kind of organism this is, so that we can tailor make treatment, because some of these some parasites are not really amenable to give an example. Vivax, your artesunate and lumefantrine, for example, doesn't really work on artesunate and sulfadoxine pyrimethamine is not really a great drug for Vivax, for example. So the only way to really find out is ask them to do a thin film and a thick film. Again, back to second year microbiology. uh, you should, if a good thin film is that through which you can read a newspaper headline when you keep the slide on top of it. Dengue NS1, IgG, IgM. Again, it's important to kind of be familiar with the seroconversion of dengue NS1, IgG, IgM. Now, quickly, NS1 is in the first week. After that, IgM comes. So if you have NS1 negative, IgM positive, that basically means the patient has had either a recent infection or an ongoing infection, in which case you repeat uh, dengue and IgG, IgM after a week. And if IgG has not appeared, that basically means this is possibly from a recent infection. Or if IgG has not appeared, it's possibly an ongoing infection. So there is the entire flow chart you can be familiar with. Lumbar puncture and CSF in case of meningeal signs. Leptospira IgM is one of those specific tests we need to start with, particularly if the patient has liver function abnormalities or if the patient has conjunctival suffusion, for example. Now, urine Legionella antigen, it's available in a lot of places, and please do send it, particularly in patients who have whose presentation is pneumonia. TB gene expert, again, for just presentations. Hepatitis panel whenever you get whenever you say liver involvement. Herpes simplex virus PCR for patients who presents with encephalitis. Stool for ovacyst, not really very relevant in the ICU, but if you are suspecting anything, just get it done. Sometimes in the urine, you tend to pick up schistosomiasis, which can lead to UTI and then cause complicated pyelonephritis. But short of that, most of our helminthic diseases don't really land patients in the ICU, except for echinococcus. I forgot about that. Now, this is your step one. Or now, if these don't work, this should have been step two. I'm sorry about that. Now, the next step would be going to the more specific ones. The more specific ones is you have done all these tests, you have not found anything. Now I want to see what next is to be done. Now, multiplex PCR in modern ICUs we don't really, it's not really step. It can be step one or step two, depending on when the patient is coming in. BioFire SA is one of those. It's basically one of the brand names for a multiplex PCR. There are multiple ones. I like BioFire because it's US FDA approved and it's also validated in multiple uh, s- studies across the world. And now recently there are some other tests also, which multiplex PCRs are also, which have been validated. So it's important to find out that, because there are so many out there in the market, it's important to find out who has validated these PCR multiplex PCR panels, and try and not send an unvalidated lab. And I don't want to take names, but we do have a few of those in Bangalore as well. And if the index of suspicion, for example, there is an encephalitis, you've done an LP, you're not going to do an LP again and again, you can choose to send the multiplex PCR initially itself. For those of you who don't know what a multiplex PCR, it basically is a PCR panel which detects multiple organisms. So there is an encephalitis panel, there is a diarrhea panel, there is a pneumonia panel, there is a sepsis panel. Basically, it's a collection of various panels, and some diseases you may have to actually go through the panel. And if, for example, if you're suspecting chlamydia or hantavirus, you may have to specifically ask for it. Rickettsia also is something which is not commonly covered in PCR panels. One, because they're expensive, and not many labs actually have the kits to do it. You may have to specifically ask for rickettsial PCR panels. But as opposed to earlier, they are available in the country in some places. Now, scrub typhus IgM, since once you suspect rickettsia, scrub typhus IgM is a little more, it's a little less expensive and more easily available. And if you're living in a place where there are severe resource constraints, wheel Felix is decent. It's not, the fidelity is not as good as a scrub IgM or a PCR panel, but if in the right settings, the right kind of case, right kind of mix of symptoms, right lab parameters, it might just be, it's going to be very useful. Chlamydia and hantavirus PCR. Interestingly, we had a case recently where the patient's presentation was encephalitis, was admitted, and there was not really much of pneumonia. And later on, chlamydia was positive for this patient. It's one of those interesting cases. And places where your Kala Azar is endemic, RK39 is available in government centers for free. You should probably get these done. Bone marrow culture and all comes next when you don't really find anything. And biopsies of relevant organism is also the next step once you don't find any cause. No, broad approach to treatment, uh, like I alluded to earlier, almost all syndromes, the treatment for most tropical infections is supportive. Some diseases do have specific treatment, but one good thing about tropical infections, either they don't have treatment or ceftriaxone and doxycycline covers for them. So it's very interesting where how so many of these atypical infections respond so well to doxycycline and even azithromycin. So fever with thrombocytopenia, the poster child for the disease is dengue. So fever, treat the fever, antipyretics, be liberal with it, and IV fluids, platelets, anticoagulants, platelet transfusion only if the platelet is less than 20,000, or if the patient is bleeding, or if it has dropped more than 10,000 in the last 6 to 12 hours. There is no role for steroids. We have gone through this. Specific therapy once diagnosed. Now, for all the other conditions, fever with jaundice, AKI, encephalopathy, respiratory distress, there's some difference. The broad theme remains the same. You give supportive therapy, start ceftriaxone, start doxycycline, and escalate antibiotics as needed. And for kidney, start dialysis as needed. Encephalopathy, take care of the airway. You also can add acyclovir in the right settings, and also managed raised ICP with 3% saline or mannitol. Now, I know this slide is a little wordy, but this is how it is. Respiratory distress, oxygen, NIV, intubation, ceftriaxone, azithromycin. And if COVID or H1N1 is a concern, just treat it based on that. Now, if you're suspecting uh, typhoid, just a word of caution, it is very uh, tempting to start somebody on ofloxacin and metronidazole the moment you're suspecting uh, typhoid. Now, incidence of ciprofloxacin resistance has been reported anywhere between 40 to 80%, an average of 70%. It's widespread, doesn't really work. So quinolones don't really work for typhoid and many other infections actually. So, and it's also a second line, some of your quinolones like levofloxacin, moxifloxacin, it's also a drug which you use for, MDR tuberculosis. So preserve them. And paratyphy, the same goes for paratyphy as well. Now, I will pause here. Maybe we can talk about the rest of the diseases in the. I'll just share one more slide. Treatment of complicated malaria. Will not go through much of detail. So this is just start parenteral therapy. Give it for at least 24 hours. And once the patient is able to take orally, switch over to an oral regimen. Artesunate 2.4 mg per kg. IV is the dose that we use. Yes, Harshini, you have a question? And one thing which is very specific in the National Malaria Guidelines is artesunate plus lumefantrine for patients who are from northeastern states. I will stop here for the want of time. We can talk about the rest of the diseases in some of the coming presentation. Any questions?
Thank you, Sanu. It was very good. I think Harshini had a question to ask. Harshini Dolly. She's put her hand down anyway.
Hello, doctors. We can have an interactive session for 5 minutes. If someone have doubts, please. This will be a great opportunity to interact with leaders in critical care like Dr. Shashi Bhaskara Krishnamurthy, Sanu Anand, Dr. Dilip, Dr. Partha Sarath.
No questions? Either understood everything or didn't understand anything. One of them. Yes, Sweetie and...
Sir, good morning. My question is not directly related to the topic. It's like when we admit patients with the tropical fever and all, you're not like they keep having these spikes, right? Fever spikes, and sometimes if there's a need to transfuse like blood products and all, you've got this dilemma like, do you need to transfuse once the fever goes treating fever? We sometimes have cases where we need to transfuse blood products, right? So most often it's recommended not to do so when the patient is running a fever. But then in these cases, they'll usually have fever spikes every now and then. So do we need to go on with the transfusion, or do we hold it until the fever goes down?
Yeah, so if there is an indication for a transfusion in critical care, typically unless the hemoglobin is less than 7, or in cases of acute coronary syndrome, less than 10, there is no indication to transfuse anything. Platelets, of course, like I said, less than 20,000, you need to transfuse. I tend to wait until 15K, but it's something which you need to take a call on. If it's a life-threatening problem and you need to transfuse, you need to transfuse. But generally, fever is not a contraindication for any kind of transfusion. Yes, Dr. Anand.
Thank you, Dr. Sanu. Very good presentation. I joined only halfway through. My question is related to typhoid. In a peripheral hospital where blood culture results are going to come a bit late. What do you recommend? Do you recommend doing the Vidal test, or based on that you start the treatment? and just this is the thing which I don't understand much, the vital test, and how you said the sensitivity is only 80%.
That is the typhoid dot. I was talking about the typhoid dot test. Viral test has multiple problems, and it's been kind of obsolete.
Okay.
One of the reasons why viral test is obsolete, it's 123 years old. I mean, name one other test. Now it's I think 125 or 126 years old. So it's that old. We don't use tests which are more than 100 years old, but to diagnose anything in modern medicine. And
Okay.
also agglutinins which are present in the viral test are not standardized across the globe. And the tube test which is actually done needs quite a bit of expertise to do. And I don't think the current generation is even very well versed with this particular way of doing the viral test. And there are a lot of cross reactivities with malaria, dengue, miliary TB, endocarditis, brucellosis, chronic liver diseases, a number of diseases which cross react with viral agglutinins. So, and also the titers are also important. So there are multiple problems. So if you have to use one test, I would use typhoid dot.
Typhoid dot, is it? Okay. Thank you. Thank you. I didn't know of that test. Maybe I can bring it to my hospital. Thank you.
Yes.
Yeah,
But
just one more point, Sanu, if I can add to Dr. Ramaputhi's question. It's around, I think the sensitivity of actual viral is around 60%, which is hardly better than a coin toss. And
Okay.
that means that, so I was reading about this sometime back. I think many of our teams order a viral, but there's a lot of wastage of resources there because it doesn't add anything to the diagnostic value. I think having spoken to someone in diagnostic immunology sometime back, they said that the only way you can actually use Vidal is if you have true clinical features of dysentery, do a Vidal test which is quantitative, and then follow it up with a repeat Vidal on the titers 2 weeks later to show that the titers have increased after the dysentery. And that is probably the only way where Vidal would be useful, because I think around 80 to 90% of the population is going to be Vidal positive just for the fact of them having lived in the Indian subcontinent. So when you're such a large population has circulating antibodies against ONH antigens, it is extremely unlikely that will ever be a useful test. That is a background on why Vidal is essentially useless in today's day.
Thank you. Thank you very much for this enlightenment. Thank you.
Devika Devraj has a question on when should we refer a patient to a higher center with thrombocytopenia? Now, thrombocytopenia is not really an indication to refer the patient anywhere. I mean, to be honest, it's not an indication to refer a patient even to the ICU. Most thrombocytopenias can be managed in the wards, and the most common ones that you do see are dengue cases with thrombocytopenia. And out of the thousands of cases that our team has collectively seen, none of us have actually seen a patient bleed because of dengue-related thrombocytopenia. It's the patient almost always crashes because of dengue hemorrhagic fever, which is unrelated to the platelet count. It's a completely different mechanism. I mean, we'll talk about it in some other session, and that happens in relatively young patients, and it's related to an immune-mediated response in the body. So we should refer a patient to a higher center if the patient is sick, if the patient is hypotensive and you don't and has organ dysfunction after doing the initial resuscitation. If you're unable to manage the patient in your center, if you do not have the resources, then you should refer. Thrombocytopenia alone should not be a criteria. But one place where I would refer a patient to a higher center is one, if I don't have a blood bank and I am not able to procure blood immediately or blood products of platelets immediately, and the patient's platelets are rapidly falling in the within 8 hours, if it falls to the tune of 50%, anywhere between 40 to 50%, that's the time you should refer, only because you don't have blood bank. Any point in repeating Vidal after 2 weeks of treatment? Do you expect it to decrease as it is an antibody test? Yeah, that's Benjamin. That's a question Philip just covered. There are multiple criteria you need to kind of fulfill for Vidal to be even relevant. I mean, my advice is don't use it. Yes, Dr. Mohammed.
Sir, I have another doubt. Like when we sometimes we get patients whose fever doesn't break even when we put him on a paracetamol infusion. So some consultants, they prefer to continue the infusion, some add mefenamic acid. So what's the better choice in treating such a patient?
Mefenamic acid. So, yeah, I mean, it number one priority is, of course, finding out the cause of the fever, and that should address your fever problem. But as far as antipyretics go, I do agree some drugs like mefenamic acid or sometimes even ibuprofen has whatever works. There are tons of NSAIDs. One thing which is important to remember is try and avoid stuff like aspirin, the other and anything which is actually increase your bleeding in patients with thrombocytopenia, or NSAIDs in patients who have acute kidney injury. If you want to go ahead and use mefenamic acid, if it works, that's fine. Sometimes a good cold compress itself works well enough. And actually, another thing, your paracetamol has a good, therapeutic safety range. So you can go up to grams a day of paracetamol itself. Sometimes we just give something like 500 mg and think it's not working. You can actually go up to 1 gram TID, and if that is not working, add an additional drug, no problem. I think we've run out of time. Any further questions, please reach out to me or Shashi or Edwin. We will have it addressed. Thanks everyone.
Thank you, everybody. Thank you.
Thank you, sir.
Thanks on great session. Anything in critical care, let's do it. Thank you.